Hello, can you hear me? Hello.
Yes, we can hear.
Hi, Dr. Ratna. nice to meet you. We have been communicating just over the phone. Hello.
Hi, Prof. Yes, we can hear you.
Hi. So, Dr. Ratna, I thought that you said that it's going to be primary care doctors, right? So, is it also will the audience also comprise other staff members in the clinic or?
Yeah, in the clinic and
Uh-huh.
also private hospitals.
I see, but it's all medical professionals.
Yeah, most of the medical professionals.
Yeah, okay, sure, yeah.
Okay, Prof.
Hi. So shall we, so my background is okay. Shall I share the slides so that can make sure everything is uploaded? Shall I share screen now itself?
Yes, can, Prof. Because you are the co-host,
Yeah.
our medical advisors are helping you with that, I think.
Okay. Okay, sure. Okay. So yeah, because I'm terrible at this, I sometimes have a few problems. So this I just want to check everything is okay. So okay, so this is it. You can see my slide, my first slide?
Yes, I can see it.
The title slide, okay, yeah, sure. Okay, so maybe I'll just leave it here. Then when, you know, it's time to share, I will just go to presentation mode. Will I have to stop sharing, unshare so that you can share your slides?
Actually, you can control from there.
I can
And
control that, okay, yeah.
as slideshow, please.
Okay,
Slideshow,
sure.
please.
Oh, you want to see the slideshow? Okay, sure,
Yeah.
sure. Slide presentation, okay, yeah.
Oh, that's good.
Yeah, okay, yeah. So Ratna, your clinic is a designated clinic for uh, transgender patients lah. Like
Actually,
Hila's clinic, is it?
yeah, correct. We are having
Okay.
our key populations. We have what we call is as KK model in KKM. So we are having all these key populations and we are treating them as well for HIV and for other STD disorders.
Okay, sure, yeah. So you will also see regular patients and then you have a special clinic for these patients?
Yes, yes.
Okay. And so how many transgender patients would you have in your clinic?
As for me, I think I have about a number, not so many, about 10.
10, okay. 10. It's better than me because I don't know why, but since the pandemic, like I don't think I've seen anybody. And even before that, I don't know whether it's because of the cost of things in university, hospital, you know. Generally, patients come for advice once or twice, then they don't come back. I think that after they've got the advice and then they probably are self-managing themselves. Yeah. Yeah. So yeah, we just have a handful, but they haven't been really coming for their follow-up during the pandemic, especially. Since the pandemic, I've not seen anybody.
Most of them are actually self-purchase.
Yeah.
But in clinic kesihatan, we actually, I'm not sure of how to approach them and monitor them.
Yeah.
You know, in terms of anthropometric, the metabolic component and etc.
Yeah. Yeah, that would be the main thing. Same thing for me as well. Yeah, most of them, you give them advice and then they make a decision on what they want to do, and most of the time they self-purchase. Yeah, because the best treatments. Norma is calling me. Wait a minute.
Oh,
Yeah.
okay.
Hello. Yes, Norma. Yeah. Oh, I see. Oh, okay. Yeah. Okay. Yeah. Okay. Thanks. Okay. Bye. So I think Radna, I will. It's going to start in a minute. Okay, so I'll just hang on here.
Okay, Prof. We'll invite you later, yeah? Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Saya rasa belum terlewat lagi untuk saya sampaikan ucapan selamat Hari Raya kepada semua para muslimin dan muslimat. Yang saya hormati, Prof. Dr. Sherin Ratna Vetakan daripada Jabatan Perubatan Pusat Perubatan Universiti Malaya selaku penceramah jemputan pada sesi CME Think Tanker JDT pada hari ini. Yang berusaha, Dr. Normawati Ahmad, Ketua Penolong Pengarah Kanan, Unit HIV, STI, Hepatitis C, Bahagian Kesihatan Awam Jabatan Kesihatan Negeri Johor. Tuan-tuan dan puan-puan serta hadirin sekalian, ini merupakan sesi kedua slot JDT Think Tanker yang mana kali pertama telah pun diadakan pada 11 hari bulan Mei 2022 yang bertajuk HIV Pre-Exposure Prophylaxis The Basic. Selamat pagi dan salam muafakat Johor kepada semua yang telah dapat hadir pada sesi hari ini dengan slot JDT Think Tanker yang kedua kita pada hari ini yang sangat menarik bertajuk Hormonal Therapy in Transgender, The Need for Holistic Care. Jarang-jarang kita dengar tajuk sebegini dikeudarakan dan harap para hadirin sekalian can stay tune sehingga ke tamat rancangan dan kita jemput pakar jemputan khas iaitu pakar perunding kita daripada Pusat Perubatan Universiti Malaya yang sememangnya pakar dalam hal ini. Saya adalah Dr. Ratnawati binti Rahman, pakar perubatan keluarga di Klinik Kesihatan Batu Pahat, Pejabat Kesihatan Daerah Batu Pahat yang akan menjadi moderator pada slot hari ini. Bagi memohon keberkatan dan keredaan daripada Allah Subhanahu Wa Taala dalam sesi ilmu pada program kita pada hari ini, saya ingin menjemput Encik Hairul Esma bin Masnin, penolong pegawai perubatan Klinik Kesihatan Parit Raja yang juga merupakan kaunselor HIV Pejabat Kesihatan Daerah Batu Pahat untuk membacakan doa. Dipersilakan Encik Hairul Esma.
Bismillahirrahmanirrahim. Alhamdulillahirabbil alamin wassalatu wassalamu ala asyrafil anbiya'i wal mursalin wa ala alihi wa sahbihi ajmain. Ya Allah, ya Rahman, ya Rahim, hanya padamu saja kami panjangkan kesyukuran atas segala rahmat dan berkat-Mu. Bersempena dengan majlis pada hari ini, kami memohon inayah dan taufik-Mu, kurniakanlah kesejahteraan dan kebahagiaan kepada kami. Bukakanlah hati kami, lapangkanlah dada kami, supaya kami dapat mengisi ilmu dan pengetahuan yang berguna untuk agama, bangsa dan negara. Kami memohon kepadamu agar Engkau berkatilah majlis ini dengan limpah rahmat-Mu. Semoga segala usaha kami dalam menjayakan majlis ini mendapat keredaan dan hidayah-Mu. Sesungguhnya pada hari ini kami berkumpul kerana-Mu, ya Allah. Kami berkumpul untuk menimba ilmu, bertukar pendapat, menyumbangkan buah fikiran, menghubungkan silaturahim dan memberi sokongan ke arah meningkatkan lagi prestasi kami. Kami memohon kekuatan dari hadrat-Mu, ya Allah, supaya kami hadir pada hari ini agar kami dapat melaksanakan segala kebajikan, dan kami mohon perlindungan dengan Engkau daripada melakukan keburukan. Rabbana atina fid dunya hasanah wa fil akhirati hasanah wa qina azabannar. Sallallahu ala sayyidina Muhammad wa ala alihi wa sahbihi wasallam. Walhamdulillahi rabbil alamin.
Amin amin ya rabbal alamin. Alhamdulillah. Untuk pengetahuan semua, bersama-sama kita pada hari ini juga adalah penyelaras teknikal iaitu Dr. Fadlun binti Hanafiah dan juga penolong pegawai perubatan Encik Taufik Yazid Reza bin Hidayat yang merupakan orang kuat di belakang tabir untuk platform ini. Sebelum kita meneruskan acara pada hari ini, berikut adalah beberapa info berkaitan dengan slot JDT Think Tanker kita pada hari ini. Okey, slot ini merupakan anjuran unit HIV, STI, Hepatitis C, Bahagian Kesihatan Awam, Jabatan Kesihatan Negeri Johor yang diketuai oleh Dr. Normawati binti Ahmad dengan kerjasama barisan portfolio HIV di kalangan pakar-pakar perubatan keluarga negeri Johor. terdapat satu lagi slot yang akan menyusul pada bulan ini yang akan dimaklumkan kemudian. Ya Prof, untuk makluman Prof Shurin dan semua yang hadir, slot ini dihadiri oleh anggota-anggota kesihatan yang terdiri daripada mereka yang anggota kesihatan di klinik kesihatan, hospital kerajaan dan juga hospital swasta serta klinik swasta dan juga NGO yang terlibat dalam program HIV di negeri Johor. Objektif slot JDT Think Tanker kita pada hari ini adalah yang pertamanya untuk memberi pendedahan dan pengetahuan asas kepada anggota-anggota kesihatan berkaitan dengan pengurusan kes di kalangan key population terutamanya transgender. Yang keduanya, untuk membantu anggota kesihatan sama ada di fasiliti kerajaan ataupun di fasiliti swasta untuk mengaplikasikan pengetahuan yang telah dicerap pada hari ini kepada golongan-golongan yang memerlukan, terutamanya di kalangan key population atau kumpulan berisiko tinggi. Okey, objektif yang ketiganya adalah untuk memberi pengetahuan tentang penggunaan rawatan hormon kepada anggota kesihatan di kalangan key population, terutamanya transgender. Okey, slot hari ini saya ingin maklumkan disediakan melalui dua platform iaitu Zoom dan juga YouTube. Peserta yang mempunyai masalah atau mempunyai soalan untuk penceramah bolehlah mengutarakannya di ruangan chat box. Okey, bagi memastikan program ini dapat berjalan dengan lancar, peserta diminta untuk memastikan notebook ataupun desktop serta mikrofon atau speaker berfungsi dengan baik. Peserta juga diingatkan untuk memakai pakaian yang sesuai dan sopan bagi memastikan persekitaran paparan video adalah kemas, bersih serta tidak bising supaya menjamin kelancaran program pada hari ini. Peserta digalakkan untuk melabelkan username ID masing-masing dengan nama penuh dan ataupun tempat bertugas mereka atau memperkenalkan diri dan tempat bertugas di ruangan chat box. Peserta amat digalakkan mengguna sama aplikasi mengikut fasiliti masing-masing berbanding dengan penggunaan secara personal bagi memastikan kelancaran sesi. Peserta juga perlu meletakkan mod video sepanjang sesi berjalan bagi memudahkan urus setia untuk mengenal pasti peserta-peserta yang menyertai sesi ini. Peserta perlu meletakkan mod mute sepanjang sesi berjalan. Peserta yang mempunyai soalan sahaja yang akan dibenarkan untuk mengaktifkan mod speaker bagi sesi soal jawab. Peserta yang terlibat hendaklah bersama-sama berada di sepanjang slot ini dijalankan dan perlu mengisi link ESPK bagi anggota-anggota daripada negeri Johor dan juga Google Form bagi anggota yang berada di luar negeri Johor sebagai bukti kehadiran dan kelayakan untuk mendapatkan mata CPD yang akan diberikan hanya pada penghujung slot ini ya. Jadi peserta yang tidak mematuhi tata cara ini akan dikeluarkan daripada slot ini dan program ini. Saya harap anda semua boleh memahami semua platform dan terms and conditions dan saya rasa tanpa membuang masa, saya ingin memperkenalkan penceramah kita pada hari ini iaitu Prof. Dr. Shurin Ratna, anak perempuan divivietakan. Kebetulan nama kita sama ya Prof? Semua saya moderator, Prof adalah penceramah. Okey, terlebih dahulu saya ingin meminta izin untuk menyampaikan CV Prof dalam bahasa Inggeris. Prof. Dr. Shurin Ratna adalah merupakan she is actually a professor in general medicine and endocrinology, Faculty of Medicine, University of Malaya from January 2019 till present. She was also associated professor in general medicine and endocrinology, Faculty of Medicine, University of Malaya since 2013 to 2018. And also was head of division of endocrinology department of medicine, University of Malaya from 2012 to 2020. She actually graduated from Bachelor of Medicine and Bachelor of Surgery, University of Malaya in 1994 and attained her Masters of Medicine in University Kebangsaan Malaysia in 2001 and also has Doctorate of Medicine from University of Melbourne in 2011. She has her own areas of interest and expertise, that is a few of them: non-alcoholic fatty liver disease, gestational diabetes and diabetes in pregnancy, lipotoxicity, assessment of beta cell function and insulin sensitivity, islet transplantation, vitamin D insufficiency, and postmenopausal osteoporosis. Wow, that is great, Prof. There are no doubts that great minds are capable of doing great things for the country. Being a professor and academicians, she has a long list of publications that I won't go through today, but the publications has been a great honor and great influence to us. Prof. Sherry, apa khabar, Prof? How are you?
I'm fine, Ratna. Thank you for inviting me to this think tank session. I'm looking forward to it.
So grateful to have you with us today. Dan dengan itu, saya menyerahkan slot ini kepada penceramah kita. Dengan segala hormatnya, dipersilakan. The floor is yours, Prof.
Good morning, everyone. Thank you for attending this session. Once again, I want to thank Dr. Norma and Dr. Ratna and the organizing committee for the very kind invitation. Let me see if I can share my slides. Can you see my slides? Can you see the title slide, Ratna? Can you?
Sorry, Prof, not at the moment.
Okay. So I think I have to probably have to share again. Sorry for the technical issues. Let's see. Share. My God. Okay. Can you see it now?
Yes, Prof.
Okay, that's great. Okay.
Only that, can you please make it as a slideshow?
Yes. Okay.
Yes.
Yeah. Okay.
Nice.
My talk today will be entitled Hormonal Therapy in Gender Dysphoria. So, although we are used to using the term transgender, technically the correct phrase or rangkap to use is gender dysphoria. So but it's a bit of a mouthful, panjang sikit dan susah sikit nak cakap. So sometimes I will use the word transgender, but I just want you to know that the correct medical term for it, which most societies advise us to use now, would be gender dysphoria or gender incongruent disorder. Okay, so what is gender dysphoria? So we are all used to cisgender people. Okay, so a cisgender person is someone whose physical body or biological gender is the same as their gender identity. So someone who has gender dysphoria, on the other hand, or more commonly known as transgender, is someone whose physical body is incongruent with their gender identity. Now, before we go on to the actual topic of this discussion, which is hormonal therapy, I think it's important to set out the prerequisites, that patients have to undergo, the prerequisite steps before we actually start hormonal therapy. Okay, so before beginning therapy, it's really important that you confirm that the subject is truly GD or gender dysphoric, okay, or transgender. Okay, so a psychiatric evaluation is really important. Okay, so the patient that you're treating, the person that you're treating needs to see a psychiatrist, and you need written confirmation, that the psychiatrist has talked to them, spent time with them, and then the psychiatrist comes up with a letter and says, yes, I believe that this patient truly fits the criteria for transgender. Okay, because hormonal therapy, can cause some irreversible changes. So the person and the medical professional needs to be sure that this truly is gender dysphoria, and that is defined according to the psychiatric DSM criteria and various other criteria. Okay, so once you have confirmed that this person truly has gender dysphoria, the psychiatrist has sent you a letter and confirmed this officially, then you need to discuss the pros and cons of hormonal therapy. This is because hormonal therapy, as I mentioned, can cause some irreversible changes. It can affect fertility, the ability of the person, you know, to have children that have their own genes. Okay, so that's important. And you also need to discuss the complications of hormone therapy and the need for close monitoring for the cardiac and metabolic side effects of some of these therapies. Okay, so discussion of the complications is important before you start the therapy. Okay, and of course, you know, if they decide to go on to surgery, which is not available in our country, but some patients may go for surgery in gender reassignment surgery in other countries, that is an even more important, you know, turning point in their life. Okay, and they need to think about that carefully because there is no turning back from surgery. Okay, so step one, as I said, consult a qualified psychiatrist. Okay, and then you need written confirmation of this gender incongruence. And the psychiatrist will use the DSM-5 criteria, okay, or the ICD-10 criteria. So the difference between these two criteria is that the DSM-5 only requires that, you know, the subject has, you know, had then gender dysphoria and features consistent with it for a minimum of 6 months. Whereas the ICD-10 requires 2 years of the desire to live and be accepted as a member of the opposite sex, usually accompanied by the wish to make his or her body as compatible or congruent as possible with the preferred sex through surgery and hormonal treatments. Now, the principles of treatment, first you need to choose the correct type of hormonal therapy. So when we're talking about transgender male to female, okay, and you need to give them estrogen therapy. There are various different types of estrogen therapy. We'll talk about the pros and cons of each type, okay? And the opposite situation would be if you're changing from female to male. Again, there are various ways of administering testosterone, okay? And then as the managing doctor, you know, you also need to know about the onset or time course of the physical changes that will occur once you start hormonal therapy, okay? So, you know, these changes are not instantaneous, you know, and the patient needs to have realistic expectations, okay, as to when they will start to see changes and what kind of changes they will see, you know. For example, you know, changes in, if, you know, the biological gender is male gender, okay, even though you start estrogen therapy, they need to understand that, you know, there will be no changes to the bone structure, okay? So there will be some softening of the facial appearance, but facial features, okay? But of course, you cannot change underlying bone structure and the prominence of the Adam's apple, etc. So the patient needs to know when the changes will start to occur, which changes are possible, which changes are impossible, etc. Okay, so that they have reasonable expectations. Okay, then when it comes to monitoring the patient, okay, so first of all, you need to monitor their own biological hormone levels, okay? And then you need to monitor the introduced hormone levels. So what do I mean by this? So when you're going from male to female, okay, you're going to give estrogen therapy. So the estrogen therapy has two purposes, okay? So to suppress the patient's own testosterone levels and to raise the estrogen levels within the patient into the normal range, okay? So you monitor their own endogenous biological hormone and you're hoping to suppress it, and you monitor the level of the hormone that you're introducing, okay? And lastly, you want to screen for and detect and prevent complications of the hormonal therapy. And long-term care as they age, as any other person, okay, there is a risk of developing osteoporosis, and you know that the sex hormones, male and female sex hormones, play an important role in bone health. So osteoporosis would be of concern, okay? If the person is born male, then of course they will have the same prostate cancer risk as if they have a family history of prostate cancer, as somebody who is not transgender. If they are female, if they have a strong family history of breast cancer, etc., they will also have that breast cancer risk. And if you're converting from male to female as well, so since males very rarely can also get breast cancer, and you're giving them lots of estrogen therapy, they might also be at risk of breast cancer as well. So as I mentioned, okay, you need to discuss options for preserving fertility. And in your patients, they may need to consider sperm banking or egg storage, okay, so that in the future, if they do decide to have children, okay, at least their own genes may be able to pass on rather than using a surrogate or adopting somebody, etc. Okay, and secondly, before starting hormonal therapy, you want to look for medical conditions that may already be existent, okay, that may be worsened by their own hormones and introducing other hormones, okay. So if you're giving estrogen therapy, you know that high levels of estrogen can predispose you to deep vein thrombosis, blood clots in your calves, okay. So if the patient has a past history of DVT or some clotting disorder, okay, the risk needs to be discussed with them. If they already have high weight, high BMI, or they are obese, or they already have diabetes and high triglyceride levels, hypertension, heart disease, or gallstones, all these conditions are worsened by very high levels of estrogen. Okay, so you need to look for these premorbid or comorbid conditions before starting therapy, and warn the patient of the risk of worsening them. Or if the patient is perfectly healthy, you need to warn them that hormone therapy may result in these complications, but you will then monitor for them. Now, another essential point is that before you actually start hormonal therapy in someone who is transgender, you need to exclude pathological causes of gender dysphoria, an actual disorder, okay? It may be a true physical cause of sex hormone abnormalities. For example, they may have, of course, this is all very rare, but you never know that such a patient may come to you. So this patient actually may have, say you have someone who's born male, but if you find out that their testosterone levels are actually low, okay, so this is actually a physical cause of sex hormone abnormalities, okay? Perhaps they have some primary testicular disease due to mumps infection or something like that, and that's causing low testosterone levels. And perhaps the low testosterone levels are contributing to the patient's desire to be of the opposite gender and being more feminine, okay? Other more serious conditions would be something like Cushing syndrome, okay, which commonly occurs in women, and it can be associated with hirsutism or hairiness and virilization because you have a tumor in the adrenal gland that is secreting a lot of cortisol and also secreting a lot of testosterone, okay? And then you have congenital adrenal hyperplasia, okay? This is something that manifests usually in puberty. A girl may not attain menarche, okay? You will have primary amenorrhea, and you have a very tall girl with hirsutism and failure to attain menarche. So these are all actual physical causes where if you measure the estrogen or testosterone, they will be inappropriate, and they should be seen by endocrinologists and treated accordingly. Okay, so examples of the physical disorders would be CAH, Maybe they have some genetic disease that causes androgen insensitivity syndrome, where they are actually XY genetically, but the cells or organs are not sensitive to the effects of testosterone, and so they appear female. Okay, so these are all rare endocrine disorders, and I think, you know, all patients who do have gender dysphoria need to be seen by a psychiatrist. They also initially need to be seen by an endocrinologist who can exclude all of this by history and examination and some blood tests, and then go on to starting hormonal therapy. And of course, the care has to be holistic. You know, it's you know, as with many chronic conditions, you need multidisciplinary team management, and subsequently, you know, the family physician can take the lead. Okay, once you have established, the psychiatrist has seen, endocrinologist has, you know, ruled out actual physical diseases, okay, or genetic conditions, and initiated and started therapy, then it can be co-managed with the family physician, who can monitor the patient and, you know, perhaps see the patient more frequently and build up rapport, and you know, and have a chronic management co-sharing model. Okay, or they could have a pituitary tumor resulting in hypogonadism, tumors secreting estrogen and androgens, etc. Okay, so all this can be ruled out by history examination, some simple hormonal tests, you know, LH, FSH, testosterone, estradiol, prolactin. And if you suspect some genetic disorder, you can order genetic studies and scans, etc., as needed. Okay, so now we'll talk about the actual hormonal management of transgender persons. Okay, so we'll start with what is a little bit more difficult, male to female. Okay, so so it's important to manage expectations, because you don't want them to you know, expect, you know, quite unrealistically extreme outcomes. Okay, so so the goals of hormonal therapy. Okay, first, like I said, you want to suppress their own natural hormones, okay, testosterone, and you do that by giving either an estrogen or anti or androgen or progestin. Okay, so an example of anti-androgen would be something like spironolactone, which we sometimes use, or cyproterone acetate. Okay, so by suppressing testosterone, then you will reduce their facial hair, their chest hair, axillary hair, pubic hair, etc. You will cause shrinking of the testes and penis. Okay, and you're also giving estrogen because you want to feminize the patient and basically replace the patient with female hormone. Okay, and these physical changes that are produced by the hormones will in turn result in mental well-being. But as I said, you know, it is important to for the transgender person to be realistic, that sometimes you cannot produce bony changes, like I said, in the jawline, and you know, the Adam's apple will still be there and present, etc. And the time onset of all the physical changes also needs to be explained to the transgender patient. Okay, so the effects of estrogen, it will result in feminization. It's good for the bones. Okay, that's on the plus side. And then here in this other column over here, you have all the complications that can arise from inappropriate estrogen therapy. Okay, so like I said, the patient would be at risk of blood clots, deep vein thrombosis, or blood clots in your coronary arteries, ischemic heart disease, blood clots in the cerebrovascular circulation, you know, transient ischemic attacks, cerebrovascular disease, etc. Okay, there will be weight gain, it can cause dyslipidemia, your LDL can go up, the triglyceride can go up, your HDL can come down. It can cause you know, high glucose levels, high blood pressure, liver disease, breast cancer, etc. So all these need to be monitored for. So in order to reduce the risk of hormonal treatment, you need to keep the estrogen level in the target range, what we call the Goldilocks range. Okay, so you remember the, you know, the fairy tale of Goldilocks, you know, where the porridge was too cold, too hot, and then there was a porridge that was just right. Okay, so we want the estrogen level to be in Goldilocks range. Okay, and the target range of estradiol, when you measure it, okay, in picogram per milliliter, okay, it depends on your center, which kind of unit you use, okay. So it's picogram per milliliter is 100 to 200, and if it's picomole per liter, as in my hospital, is 367 to 734. And you want to suppress their own hormone, the testosterone, to less than 50 nanogram per deciliter or less than 1.7 nanomole per liter. Now, the important thing to remember is that there are different kinds of estradiol therapy. And with some kinds of estradiol replacement, you can't really measure the estradiol level. So if you have a patient on Premarin or ethinyl estradiol, which patients commonly use, although they are advised not to do it because the risk of DVT and blood clots is highest with synthetic estrogens like ethinyl estradiol, which is found in OCPs. So if a patient is on that kind of hormonal therapy, then you can't really measure the estradiol. So then you can't really get into the safe target range, and you know, where you're quite sure, you know, the risk of complications is lower. So that's a disadvantage of using, Premarin or ethinyl estradiol. Whereas if you use the natural estradiol, which is identical to what females have, okay, which is 17-beta estradiol or Progynova, okay, then you can measure their levels, and then you can target your hormone therapy to achieve this Goldilocks range, okay. So which drug to choose? It's so difficult, okay. It's like a Korean K-pop band, okay. Everybody looks the same, okay. But let me show you that there are actually subtle differences between the different types of estrogens, okay. So this table over here is taken from the Endocrine Society guidelines on how to manage patients with gender dysphoria or transgender when you're converting male to female. So in this table, they don't actually include Premarin or conjugated equine estrogen or ethinyl estradiol, because this is an American society, and they do not use that at all for their transgender patients, and they use natural estradiol. Okay, so natural estrogen, okay, 17-beta estradiol, okay, can be given in the oral form, okay. There's oral Progynova, okay, or transdermal form in patch form, okay, or it can be an injection of estradiol valerate or injection of Progynova. Okay, Progynova is the trade name for commonly available natural 17-beta estradiol. Okay, so here on your right hand side over here are all the different doses that can be used. So if you're using oral Progynova, you start with the lowest dose of 2 milligram, and then you gradually increase the dose. Okay, so you don't go straight away to the high doses, because as breast development starts, there can be breast tenderness and it will be uncomfortable. So you start at a low dose and gradually increase it depending on the response of the patient and your monitoring for side effects. You know, if side effects occur, then of course you don't want to go to the highest doses, and you want to stay at a lower dose. So transdermal estradiol, I actually don't have experience using it because it's quite expensive, and the patients who have come to me were unable to afford the transdermal patch. Okay, the disadvantage of using something that is transdermal is that if they are in a relationship, then it can, especially if it is a cream or a gel, okay, it can transfer to the partner. Okay, but a patch is quite safe. It cannot transfer to the partner. And then you have the injectable forms of Progynova, where the patient will be self-injecting every 2 weeks or every week. Okay. Now, sometimes you may have to add on anti-androgens such as spironolactone or cyproterone acetate. They have benefits for reducing hair growth, etc. And it works in combination and synergistically with your estrogen replacement. And I don't have any experience using the GnRH agonists. Okay, so these are the medications that are used to treat, are also used to treat endometriosis, etc. Okay, so it will be things like Zoladex. Okay. These injections are all quite expensive, and basically the principle of giving someone a GnRH agonist is that basically you will lower their own body's endogenous testosterone levels. Okay, so these are also used in patients with prostate cancer, etc., to lower the patient's testosterone levels, etc. Okay. Okay, so now let's talk about the oral estrogen. So like I said, conjugated equine estrogen or Premarin, okay, it's not advisable to use this, okay, although it's very cheap, easily available. We use it for our postmenopausal patients, okay. The drawback is that you cannot measure the serum estradiol, okay. Then you cannot monitor the estradiol levels and cannot aim for the safe level, okay. So the best is what I have circled here, 17-beta estradiol, okay. It can be oral or IM Progynova. The benefit is that you can monitor the patient, and it's very natural because it is identical to estrogen produced by a woman's ovary, okay. And then ethinyl estradiol, that will be the worst, okay. It's found in oral contraceptives. It's synthetic. Again, you cannot monitor the safe level. Highest risk of blood clots or thromboembolism, okay, DVT and pulmonary embolism. Now, the drawback of using oral estrogen is that you have what is called a first pass effect. So going back to our pharmacology days, when we were in medical school and we were studying pharmacology, when you take an oral medication, of course, it has to be digested and absorbed in your gut, okay? And once it's absorbed from the gut, it enters the portal vein and then it goes to the liver. And that's where you get this first pass effect, okay? Where it has to first pass through the liver, and therefore it can have effects on lipids and fat and cause your dyslipidemia, cause high triglyceride and low HDL. It affects your clotting factors, and because it first goes through the liver, and it increases your risk of deep vein thrombosis, and it can also enter your bile and predispose you to gallstones, okay, when you have estrogen given in the form of oral estrogen. But when you inject estrogen, then you bypass the liver, you don't have the first pass effect, and so these side effects and complications are minimal to non-existent, okay. Similarly, if you use a patch, again, it's going straight into the bloodstream, you're bypassing the liver. You don't have the first pass effect, and you don't have that increased risk of blood clots, okay. And this is what happens in someone who is cisgender and born female, okay. The ovary secretes estrogen, goes straight into the bloodstream, it doesn't pass through the liver. So the transdermal, so we've discussed the drawbacks of oral estrogen. Let's now talk about transdermal estrogen. You can have a transdermal patch. The subject needs to change to a new patch every 3 to 5 days. And this is the range of doses you will use, but it's pretty expensive. The benefits, like I said, it goes straight into the bloodstream, no first pass effect, you can monitor the blood levels. But the disadvantage is that because it's being absorbed through a patch and through the skin, you can have fluctuating levels, okay? You can monitor it, but slightly more difficult to monitor. Injectable estrogen in the form of Progynova, you would use intramuscular 5 to 30 milligrams every 2 weeks, or intramuscular 2 to 10 milligram every week. The advantage, no first pass effect, can monitor the blood levels, but again, immediately after the injection, the levels will be high, then subsequently they will come down. So you may have some fluctuating levels. Now, what are the anti-androgens? I've mentioned spironolactone. The dose would be 100 to 300 milligrams maximum a day. Or you can use Androcur or cyproterone acetate, 25 to 50 milligrams per day. So if you combine an anti-androgen with your estrogen, you may not need to use such a high estrogen dose, and therefore you will lower the risk of blood clots and cardiovascular disease. And it has been reported, but nobody has really studied this scientifically. Actually, a lot of what is in the guideline, as family physicians, I know you're all very big and strong on evidence-based medicine. But unfortunately, in endocrinology, with rare disorders and things like this, nobody has really conducted any randomized controlled trials, and it's all based on experience and anecdotal evidence. So people say that maybe if you combine the anti-androgen with the estrogen, there is improved breast development, mood, or sexual desire, especially if you combine with progesterone. Okay, but you have to remember that actually, progesterone, is the one that is most toxic to the blood vessel and, higher risk of forming blood clots, okay, and getting pulmonary embolism, okay. But so with any form of progesterone, you have this increased risk, okay, but the risk is higher with the older medroxyprogesterone acetate compared to micronized progesterone. So I myself personally have not prescribed progesterone, but transgender patients, they're very clued in, they're bright, and they read up a lot, and they talk amongst themselves, and they have their own community. So they often self-treat, and I have had patients who have bought progesterone on their own and combined it with pro-Gynova therapy, but I explained to them they shouldn't use it for too long because of these side effects, and not at too high a dose. Okay, so then the GnRH analogs, would be, as I said, monthly injections. Examples would be goserelin or leuprolide. Okay, these are like really expensive. Okay, okay. So what are the estrogen effects, and what is the time course of the effects of your hormonal therapy? Okay, so some things are affected quite fast. Okay, so within 1 to 3 months, okay, the onset within months of starting estrogen therapy would be a reduction in sexual desire, a reduction in erections. Okay, the onset would be at 1 to 3 months, maximum 3 to 6 months. Okay, and your muscle mass and strength and body fat will also be redistributed in a female pattern, and breast growth will also occur a little bit later, within 3 to 6 months. And the maximum will be several years later. Okay, so your transgender patient needs to understand that these changes are not going to be instantaneous. Okay, you need to titrate the dose. You start with a low dose, and you monitor the patient for complications, side effects, and then as the dose increases, the changes will be seen, but it will ultimately, the full effect will be seen, 2 to 3 years later. Okay, testicular volume will also come down, the skin will soften, less oiliness, and the terminal hair growth, the hirsutism, etc., may take 6 to 12 months. Okay, and the maximum is more than 3 years. Okay, sperm production, nobody really has data on that. The effect on scalp hair is variable. Voice change, like I said, the Adam's apple, you cannot change that physically, but I believe there are ways that like voice coaches can help patients to increase the pitch of their voice, but it's not really the effect of your hormonal therapy. Okay, so this is the main worrying risk of estrogen therapy. Okay, the risk of thrombosis, then you have a blood clot in your calves, and then the blood clot breaks off, enters the lungs, and causes pulmonary embolism and difficulty in breathing. If you have a very large pulmonary embolism, okay, it can even be fatal. But if you have multiple small ones, that are undetected, ultimately it can lead to right heart failure. So you want to avoid this at all costs, okay? Now, the higher the dose, the higher the risk of DVT and PE, okay? As I mentioned, oral, because there is first-pass effect, there is a higher risk, okay? Patch and injection would be preferred, especially in an older trans woman, because as you age, there is higher risk for thromboembolic disease, okay? Now, as I said, the highest risk is for DVT, okay? This is 20 times the risk of a person who is not on hormone therapy compared to the general population. More moderate risk of adverse outcomes would be things like pituitary tumors that secrete prolactin, breast cancer, coronary artery disease, strokes, cerebrovascular disease, gallstones, and dyslipidemia. Now, how do you reduce or mitigate or prevent these complications and risks? Okay, so one, try to use an estrogen that you can monitor, Pro-Gynova. Keep the estrogen in the target range. Try to use an injectable form or transdermal form rather than an oral form. Supervise hormonal therapy is important, needs to be monitored by a doctor, and don't try, the patient should not try to treat themselves, okay? They need to see a doctor initially at least every 3 months, at least to monitor for the complications, okay? Stop smoking, because smoking can increase your risk of blood clots, deep vein thrombosis, heart disease, and stroke. Maintain a proper weight. If you're obese and overweight as well, then you're at higher risk of DVT. Reduce and stop alcohol, because remember, there can be effects on the liver due to hormonal therapy. So stop drinking and smoking excessively. If you're in a condition or situation where you're predisposed to blood clots, so what predisposes you to blood clots in your legs and calves? That would be if you're not moving much, if you're immobilized, okay, a long plane or road journey, then you need to use compression stockings and do DVT prevention exercises. Now, this same, preventive measures are applicable to someone who is not transgender, who is going on a plane journey, or who is overweight or older, or who is a smoker, or uses oral contraceptive therapy. And if for some reason, they are immobilized, they are very sick and bedbound and cannot walk, then you need to stop the estrogen therapy temporarily, because the risk of DVT is like really very high until they regain their normal mobility. So for example, if they're going for a planned surgery, okay, then you need to stop the hormones 3 to 6 weeks before the surgery, if the surgery is going to immobilize them. And if they have a family history of heart disease, then you need to be more rigorous, screen with ECG, exercise, stress tests, and monitor and treat the risk factors, for example, high blood pressure, diabetes, and high cholesterol and dyslipidemia. Now, monitoring, you monitor the physical changes. I mentioned the changes in body hair, muscle mass, etc. Okay, and breast development. Okay, and then you also do lab tests for hormone levels, their own endogenous hormone, okay, the testosterone, you want it to be suppressed, and the estrogen to make sure it's in the target range. And you monitor it every 3 months in the first year, then once or twice yearly, okay? If they're on spironolactone, that can increase their potassium levels because it's a potassium-sparing diuretic. Then you need to monitor the level every 3 months in the first year and then annually subsequently, okay? Then you look for side effects of the sex steroid hormones, okay? So periodically, maybe once a year, you measure the prolactin in case they get a prolactinoma, because prolactinomas are tumors that grow once you give someone in the pituitary gland, that once you give someone excess estrogen, okay? Then you monitor their LFT. You monitor their cardiovascular risk factors, you do a fasting serum lipid profile, you do a fasting glucose and an HbA1c, and you measure their BP at their checkups. Now, a screening for and treatment of osteoporosis, if they have risk factors as for ordinary people, okay? So for example, if they have some disease where they need to take steroids, then you screen them for osteoporosis before the age of 60. Otherwise, just as with normal people, you start screening for osteoporosis after the age of 60 as a normal woman would. Okay, breast cancer, you follow the screening guidelines for non-trans women. Prostatic disease and prostate cancer, you screen according to their personal risk assessment. So for example, if they have a family history of prostate cancer, then you need to screen them. Now, surgery for sex reassignment and gender confirmation should be after completion of at least 1 year of consistent and compliant hormonal therapy. Okay, I don't have much experience with this because this surgery is not available in Malaysia, but patients are only referred for surgery when they have had satisfactory social role change, they're happy with the hormonal effects, and they're sure they want definitive surgical changes. Okay, and such a life-changing measure should not be carried out until they're at least 18 years of age or legal age of maturity. It differs in different countries. So I'm an adult endocrinologist, so I only have experience treating adult transgender people. I can only imagine how complex it would be to treat prepubertal person who thinks they are transgender. Okay, it's very complex. Okay, so like sometimes they will give drugs to stop puberty. You know, if like say you have a girl before puberty, but she thinks she's a boy, you know. So sometimes overseas, after careful thought, consideration, and multidisciplinary consultation, if they're very sure that this is a transgender child, they may want to block puberty so that since she doesn't want to be a woman, you don't want her to, you know, attain menarche, and try to give her some time to sort out, you know, the situation. Okay, so I have no experience with this, and I'm not a pediatrician, but it is certainly very complex with very far-reaching consequences if you make the wrong decision. So I don't envy my pediatric colleagues. I'm not sure how much experience they have with that in Malaysia. Okay, now we go to the transgender man. Not as complicated as the transgender woman. The hormone replacement follows the general principle of treatment of someone who's non-transgender but has low testosterone levels, okay, either because of a pituitary tumor or mumps infection and orchitis, etc. Okay, so same principles as treatment of male hypogonadism. Okay, so usually you use injections of testosterone, parenteral testosterone administration, or transdermal preparations are also possible. Again, not commonly used in Malaysia, transdermal, okay, gels or patches, okay, to achieve testosterone values again in the normal male range. So again, here again, it's important to get that Goldilocks level, okay, which would be in the range of 11 to 35 nanomole per liter. So when you are on testosterone, okay, you will get deepening of the voice, increased muscle mass, increased facial hair, acne, increased body hair, particularly on the face, chest, and abdomen. Male pattern baldness is also a possibility. Increased sexual desire, clitoromegaly, and there will be temporary or permanent reduction in fertility, because when you give someone high doses of testosterone, then you will suppress their own endogenous estrogen levels, and periods will stop within a few months. Okay. Now, usually what is very common is that if you overdose the person with testosterone, then you will get polycythemia or a high hematocrit. Okay, that would be a hematocrit more than 50%. So that is common. So you need to monitor for that. And this is of lower risk. Okay, severe liver dysfunction. Okay, so you need to worry if your liver enzymes, your ALT and AST are more than 3 times upper limit normal. Coronary artery disease, strokes, hypertension, or breast or uterine cancer. You know, if it's a woman who wants to become a man, you know, even though they have transitioned, okay, if they have a strong family history of breast cancer, that risk will still be there, and they need to be monitored as per a non-trans person, okay, because of that strong family history. Now, the different types of testosterone therapy and female to male transition is not as complicated as male to female, okay. So what is commonly available and it's relatively affordable would be testosterone enanthate or testosterone cypionate. Okay, so usually the dose that is given is either weekly or 2 weekly. Okay, 100 to 200 milligrams subcutaneously every 2 weeks, or half that dose. Okay, every week. Okay, there is a very short-acting form which is called testosterone propionate, and testosterone propionate, if you because it's quite short-acting, you can even microdose and give it twice a week, maybe 50 microgram twice a week. But generally, enanthate and cypionate are a bit longer acting, so you shouldn't be microdosing. Again, you know, our patients all, you know, they like to discuss among themselves and read on the internet. And there's also a strong gym culture where, you know, people are taking androgens and they're discussing what is best, etc. So the latest thing that I notice among their patients is they like to microdose. Okay, they like to take the testosterone injections, small doses twice a week. Okay, I guess it's okay, yeah, as long as we monitor for the complications. Now, a longer acting testosterone would be testosterone undecanoate, okay, or the trade name for that is Reandron or Nebido. Okay, so this is actually more convenient and gives you a more steady level of testosterone levels, because if you're giving multiple frequent injections, what happens is that you get a peak and then there is a trough. It drops to below the Goldilocks range. Okay, so some patients don't like that. Some people like to microdose and get small peaks and small troughs, and they think it is more physiological. Okay, and some people prefer to take the injection less frequently, but just have a steady plateau level, which you can get with Reandron and Nebido. But the only problem is that it's quite expensive. Okay, in fact, it's very expensive. So not many of my patients are on this. Plus, they believe it is, they prefer to microdose. Okay, so this would be 1,000 milligram every 12 weeks. Okay, and then you have the transdermal testosterone. It may be a gel, it may be a patch. Okay, if it's a gel, the problem is they may transfer it to their partner. Okay, and the partner may not want higher levels of testosterone. Okay, now rarely you have testosterone pellets. Okay, so these pellets is like a small mini procedure. Sometimes they use it in Australia. You just make a small incision in your clinic. You know, it's not even in OT, under sterile conditions, and you just push in a testosterone pellet and it'll slowly release testosterone, and then you just change it every 3 or 6 months. Okay, but I have not seen it in Malaysia, but I've seen it in Australia. Literature also quotes auxiliary testosterone solution, nasal testosterone gel, buccal or bioadhesive tablets in the mouth, and oral testosterone undecanoate as well. Okay, like all these are not available in Malaysia. Now, what is the natural history of testosterone therapy? What's the onset of all the changes, and what is the maximum time point it occurs? Okay, so oiliness, acne, you can see quite early, 1 to 6 months. Okay, increase in facial and body hair, 6 to 12 months, and it peaks at 4 to 5 years. Scalp hair loss, also you can see within a half year. Muscle mass will also increase within 6 to 12 months. Fat redistribution occurs quite early, 1 to 6 months. Your menses also will stop quite early. There'll be clitoromegaly, vaginal atrophy, and deepening of the voice as well. Deepening of the voice will occur within 6 to 12 months. And this is the time point at which maximum changes occur. Now, how do we monitor the transgender men on gender affirming therapy? So they need to be monitored every 3 months in the first year, then 1 to 2 times a year. For side effects, you measure testosterone every 3 months till the levels are in the normal range. So how do we measure testosterone? Okay, so when we measure estradiol, it doesn't really matter at what time point we measure estradiol. But for monitoring testosterone therapy, you must make sure it's at the correct time. So testosterone is always measured fasting in the morning, and if they are taking injections of testosterone, it is at the midpoint. If they're taking injections of short-acting testosterone, okay, which is the testosterone which we most commonly use, enantate or cypionate, every week or every 2 weeks, then you must measure at the peak. It is the midpoint between the two injections. So if they are injecting every week, you measure the level after 3 days. If they are injecting every 2 weeks, you measure the level after 7 days. Okay, you don't want to measure it at the lowest point. The lowest point will be just before the next injection. We call it the trough, the lowest level. So if they're on short-acting injections, you want to measure it midpoint, okay? So remember, fasting, morning levels, okay? Midway between the dose, if you're taking the short-acting forms, enantate, cypionate, propionate, okay? And you want to target the mid-normal range, okay? So remember, mid-normal range would be roughly it's 14 to 24 lah. Different hospitals will be having different ranges, okay? Now, if you're using the long-acting form, the expensive Nebido or Reandron, then you want to measure it at the trough just before the next dose, and your target range there will be a bit lower, 10 to 15. If you're using Nebido and the level is less than 10, then you need to increase the frequency of injection, not every 12 weeks, maybe then you want to inject it every 10 weeks. So how do we monitor? You do the hematocrit at baseline and every 3 months for 1 year, then 1 to 2 times a year. You monitor the weight, blood pressure, and lipids regularly. Screen for osteoporosis in those who stop hormone treatment or non-compliant, okay, or develop other risk factors for bone loss. If the woman still has some cervical tissue, then you need to monitor as per a non-trans woman for non-trans man, for normal non-trans woman for cervical cancer, etc. Okay, and breast cancer screening as for normal women. Okay, if the patient has a history of mastectomy because of gender reassignment surgery, you still need to palpate the subareolar tissue. But if they still have not gone for gender reassignment, they still have breast, then you have to conduct your usual mammograms. Okay, so I will end here. And are there any questions? If you want my slides, I can give it to Dr. Ratna or Dr. Noma.
Thank you very much, Prof. I think we can actually open for the Q&A session. Is there any questions so far? Okay, Prof. But I do have questions for you, Prof.
Okay, sure.
Regarding the transgender men, they can still have menses, right? And how can it be controlled, and when can it be stopped actually? Because
Okay.
there are a few patients actually concerned about this, and is there another approach to really stop the menses?
Yeah, usually from my experience, menses is usually not a problem, okay? So within 1 to 6 months of starting testosterone therapy, most transgender men have cessation of menses. So it'd be quite unusual if they still have their menses. Maybe the dose of testosterone is insufficient, or the frequency is insufficient. So you need to consider that and check their testosterone levels. I see.
So is there any other approach that we can actually overcome it, such as maybe medroxyprogesterone acetate?
it is a possibility, but usually there are risks with medroxyprogesterone estate, you know, increased risk of DVT. So the best approach would be to try to aim for the normal testosterone level. And I mean, they need to be patient. Like, it may take up to 6 months.
6 months.
Yes.
Okay. Okay, thank you, Prof, for the answer. There's a question here regarding transgender women, where actually, despite the hormonal treatment, do they still, because you know that they want to induce their physical changes to match their gender identity. So because of the concern of the hair in their bodies, on their bodies, does they need to go for laser hair removal or electrolysis despite their hormone treatment?
Yes, sometimes, you know, the hair may not be entirely due to gender. Okay, sometimes it may be ethnicity as well. Okay, so certain ethnic groups, Indians and Hispanics, you know, even though the females may be slightly more hirsute. So it is something genetic, something ethnic as well. So if they are having problems with persistent hirsutism, despite having achieved a nice estrogen level in their bloodstream, then, you know, they might have to use physical methods, you know, initially maybe depilatory creams, you know, or waxing, etc. Or they could even try laser therapy, with a dermatologist, But again, it does, they have to give it time, and if they have given it sufficient time, okay, it might take, let me go back to my previous slide. There's the time course, here. So 6 to 12 months, and you should have like, remember, we are starting with a low dose. We start with 2 milligram, then we up titrate the dose, etc. So like, if you're given it sufficient time at that target estrogen level and the body hair is not coming down, then maybe you can try something permanent like laser therapy lah. But in the initial phases, it will be cheaper and easier just to shave or use a cream, etc., and give time for the hormones to work.
Okay, thank you, Prof.
And adding on spironolactone and the Androker also will reduce the hirsutism as well.
How about, there are also questions here. How about the those who actually wants to stop the hormonal therapy? Do they go gradually, slowly, and then stop if they want to reverse back to their normal gender?
Yeah. So I think I've not encountered this problem, but approaching it logically, you know, if they've taken this, if they've taken hormones for some time and you have suppressed their own endogenous hormones, if you do stop it, it potentially may never recover their own hormonal axis. Then the main thing you worry about would be bone health, you know. So both in a male and female, I think whether you stop it gradually or whether you taper it down, you know, it is the recovery, if at all it recovers their own hormones, it will be slow, and that's potentially it will not recover. Okay, so I think whether you stop it gradually or stop it immediately doesn't make a difference. I think it would be better to stop it immediately. Okay, unlike cortisol or thyroid function, it will not be life-threatening. Okay, but they may feel a lack of energy and low mood, etc. So it would be important to replace their endogenous, their own, the hormones they started off with, okay, while waiting for their own axis to recover, but potentially I think it won't recover. You know, I see patients like, I don't know whether they're telling me the truth, not transgender lah, but you know, we often are referred patients who say They only used, years ago, they in the gym, they used testosterone and like years later, their own testosterone is still suppressed. It's very hard to recover your own axis once you have used something external.
And also fertility.
Fertility also, so that's why they need to be sure that they're truly transgender. They need to be sure, and the psychiatrist needs to tell you that they really are, so that this problem doesn't occur where they want to change their mind. And if there are facilities for sperm banking and egg storage, that would be good. Sometimes we can use clomiphene to re-stimulate their own endogenous axis. We have seen with athletes who abuse androgens, sometimes if you give them clomiphene, even males, it will wake up their own testosterone production. You could try it lah. You could try it, or you could straight away replace their own hormones.
Okay.
Have you, Ratna, or whoever it is, like, have you had experiences of seeing patients who change their minds?
No.
Yeah,
not yet.
Because they don't offer sometimes. Especially during this pandemic, many of our patients have been lost to follow up. So long term, we don't really know whether they do change their minds. But so far, I've not encountered anybody who changed their mind.
Okay, Prof. Okay, there's another question here from Nabil Razali. The questions are the mental health problems such as depression, anxiety, and is it associated to hormonal therapy? As some believe that hormone taking do affect the feelings or moods. So how to overcome it, Prof?
Yeah, I would say that no, it's not so much the hormone therapy that you are giving them, especially if you're giving them a hormone where you can monitor the blood levels and it's not excessive, either your estrogen or testosterone. If it's within the target range that you're aiming for, so you don't have to worry that you're giving them too much testosterone and they're aggressive, or libido is too high, whatever, all these mental things, and or if your testosterone is too low, also you can feel a bit depressed or have low mood, etc. Okay, so what is probably more likely to affect their mood is like if they're not external factors, not so much the hormone therapy, or they're not achieving the physical changes that good hormone therapy would give them, or if they have unrealistic expectations of the physical changes. Because usually if you have made the correct diagnosis and they truly are transgender, you start therapy, they usually, the physical changes that they see will improve their mental well-being. So it's not the hormone that you're giving them. If it's in the right range, it shouldn't cause any, it's not the hormone therapy, it's external factors, perhaps their social circumstances are causing depression and anxiety.
So actually must explore the patient's concerns and assess them. Yeah. So another question from Nabil Razali from the chat box. What is the effect of people living with HIV taking hormone? And does antiviral drugs efficacy towards hormone taking?
That's a good question. Because I don't, because all these cases are usually managed by the ID physician if they are on antiviral therapy. So not that I know of, Nabil. I'm so sorry, I can't answer that question. I've not, because they're usually not managed by me. Yeah. I doubt it. Yeah, I doubt it. Because, it doesn't, I do not think it would affect antiviral efficacy. Yeah.
Because it's a hormone, right?
Yeah, it's a hormone, yeah, and it's not mentioned in any other guide. We don't need to monitor for it, so I very much doubt it. Yeah, but I would have to check with my ID colleagues if they know something, or Google and see if they are, but I doubt it. Yeah, I don't think so.
But I do encounter patients of mine who is actually on heart therapy for the RVD, and on also this implant on, the implant,
Yeah,
and
yeah.
the efficacy is reduced for the
This-
implant.
this-
The efavirenz that she took actually reduces
It-
the
this is
implant.
not a transgender person.
No, it's a normal person, not
It's a normal person.
That is
I
from
think,
experience.
yeah. Don't know. Usually, if you use OCPs and their enzyme inducers, then if the drug is metabolized through that pathway, then possibly, but this would only be for estrogen lah, then it would affect that drug as a drug interaction. So that is one possibility, but yeah, I don't really know how the hard drugs are metabolized, etc. Yeah.
Okay. 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 Prof, we have I think we have already at the end of the session. Just a mix bahasa here, dua bahasa ya. Jutaan terima kasih diucapkan kepada Prof Sherin kerana sudi meluangkan masa bersama-sama kita pada hari ini dan menyampaikan pelbagai ilmu related with our HIV session today. And terima kasih juga kepada semua peserta yang sedia menunggu hingga ke akhir slot. Sebarang soalan lagi boleh diutarakan, masih lagi kita boleh utarakan soalan ke chat box ataupun sesiapa yang ingin membuka sesi video ya untuk mengutarakan sebarang soalan kepada Prof. Okay, can we make a conclusion here, Prof, that every gender dysphoria must actually be assessed by a qualified psychiatrist first to confirm the diagnosis according to the DSM-5 or ICD-10, and also for the transgender male to female, remember that we are using estrogen, and we also have other options such as spironolactone or GnRH agonist, but I think no OCP, Prof.
No,
Right?
OCPs, but I know many patients use OCPs because it's affordable, but it's not safe and very high risk. Yeah.
Yeah, that is why we need to monitor. Monitoring is important. Monitoring the hormone level to the target, and also the adverse event, especially if estrogen. It is important to assess whether they have this VTE, venous thromboembolism, and also monitor their cardio metabolic outcomes. Yeah, Prof. And for transgender men, we are using testosterone. Still we need to monitor the hormone level and also less of adverse event compared to estrogen, and they have to be monitored for their hematocrit level, and also as well as cardiometabolic outcomes and osteoporosis as well.
Yes,
I
absolutely
think
correct.
that makes the conclusion of our slot today. Anything that you want to add, Pro?
No, not really. Yeah, and thank you for inviting me, and I enjoyed giving this talk.
Okay. Okay, and then jutaan terima kasih kepada semua peserta yang setia menunggu hingga ke akhir slot. Semoga ilmu yang disampaikan dapat dikongsikan kepada semua anggota dan masyarakat dan diaplikasikan dalam tugas harian masing-masing. Moga dengan usaha yang diberikan dapat merealisasikan Johor ke arah menuju sifar HIV menjelang tahun 2030. Peringatan kepada semua peserta, dimohon untuk melengkapkan kehadiran dengan menggunakan link yang terpapar di chat box, dan bagi yang tidak berkesempatan untuk menyertai slot ini, anda masih boleh melayari laman sesawang website of e-learning jknj.moh.gov.my. Jika tiada sebarang soalan lagi, saya bagi pihak urus setia memohon maaf sekiranya terdapat sebarang permasalahan sepanjang slot ini berlangsung. Saya nampak ada yang ingin mengangkat tangan untuk bertanyakan soalan. Badriah Ismail ke? Tiada? Oh, tiada soalan. No raise hand. Okey, saya bagi pihak urus setia mohon maaf jika ada sebarang permasalahan dan sampai mungkin kita bertemu lagi pada slot yang akan datang pada 25 hari bulan Mei dengan slot bertajuk SOGI, Is it a risk? Ini akan disampaikan oleh Encik Chun Han Yang. Dan saya rasa tiada lagi soalan. Terima kasih banyak Prof. Thank you very much Prof.
Thank you very much, Ratna. Thanks everyone. Hope it was
Thank you.
useful. Bye.
Okay. Bye. Dengan ini saya mengundurkan diri dan dengan ucapan Assalamualaikum warahmatullahi wabarakatuh dan bye-bye.
Minum yang betul. Kalau nak punya pasang.